Hey, thank you for the introduction, Brett. Really excited to be here today and to be talking on a subject that I feel especially passionate about. As Brett said, I'm an infection preventionist. I'm also a former SPD manager for Cincinnati Children's Hospital. They were named #1 children's hospital in the nation, but that was after I left. So I don't know how I contributed to it, whether by leaving or by being there. But either way, my background is in epidemiology, and that's an arm of public health that really deals with a lot of data and a lot of looking at how disease spreads and impacts a community from a very data-driven perspective. So today, I'm going to focus on applying a piece of lean methodology that can make your data very useful. I also want to thank Beyond Clean for giving Sterile Processing a platform and for being able to participate in this type of presentation. So, all right. So we're going to start off with a quote by Henry Adams here. And he said, "Chaos was the law of nature, order the dream of man." And we see that a lot in SPD. Nature or chaos is just kind of the name of the game. Now, that's in part because we deal with a lot of contributing factors: lack of staff, pressure for turnovers, broken processes, and technician preparedness. We also deal with a lot of things that we can't see, things going below the surface. One of the things that has been a big eye-opener from an infection prevention perspective is that sterile processing is truly the most effective arm of the infection prevention plan. Every day we see everything from telemetry to dialysis to the OR, and the processes that are built into sterile processing, the work, the passion of the team members in sterile processing allows that to be from a chaotic state into an order state. Now, when we make these observations, and we make thousands of observations a day without even noticing it. Hey, John walked in to decontam without his shoe covers. What are we doing about that? The vendor dropped off 20 trays today. There's no paperwork with them. Or, hey, I just observed that my technician is struggling to get competent with this type of tray. So those are the type of observations we make day in and day out. The value of data is taking those observations and building an aggregate. The other day here in Cincinnati, we had a lot of rain. And from the time I left work, it was just kind of little drips on the wall and then, or on my windshield. And then, by the time I got to work, it was just downpour. So it makes you think of an aggregate. So when we have all these little observations, they don't really have any impact. But then the more observations or water droplets you get, it collects and collects and collects until it's something that can actually be impactful. Think of, a hydroelectric dam that's just churning out a huge amount of power because it's aggregated small bits of observation or water droplets. Now, what we want to get to the point of is where those observations are impacting our outcomes. One way to make that happen is what's called the DIKUW model. And that's one way of observing data or capturing data and letting it build upon itself. So we're going to go through a couple of definitions here. The first one is data. And it's been a great day of presentations, and you all have heard that word probably a million times by now. What we didn't learn is whether you say it data or data, and that's still an open question. So, but what data is observations that have been collected in a structured way. Now, next we build on that and we get to the I, and that's information. So information is nothing more than data that has been organized into a way that has context, meaning, and relevance. So we'll go back to the water example. Well, there's water on the floor. Well, that's an observation. but now we need context, we need information. So water on the floor of my kitchen, very different than water into the sterilizer, very different than water in decontam. So that's why we need context. Next, the K in the model is knowledge. So that's information that has been interpreted in relation to an integrated system. And that's a lot of word salad for saying that it's applicable information. It's something that tells you what you need to know. So again, you may have technicians come to you and they say, did you know that this product is not the best product in the world? Meanwhile, you've got the OR calling and, you know, things are on fire and you're thinking, this is not important right now. It may be valuable, but the knowledge is information that's been put into relation to an integrated system. So what that means is if this biological is good or bad or indifferent, how is that affecting patient safety? And that's the thread. It was brought up in an earlier presentation that a lot of what we're doing is connecting the thread of our work to the outcome of patient safety. We may never get to see the patient. We may never get to interact with them, but we are connecting that thread. And I'll talk a little bit more about that later on. Now, next we get to the U, which is understanding. So that's knowledge that can be leveraged into change. So once you know what's going on, you know how it fits in the system, and that data has context, now you can leverage that into change. And this is where we get into getting what you need for your department. And we'll talk about how other departments and other resources, IP being one of them, can help you get what you need in your department. And then last is wisdom. And this is where we want to get to with all of our observations. So all of these observations, they collect, they aggregate. We get to a point where we know what the trends are. We build culture. We build long-term changes. There is a lot of, and you've probably worked in a department like this, or you've been in this position where you're a phenomenal leader in SPD. And you're like, I solved that problem. I know what's going on. I know how to fix it. I fixed it. You leave 2 years later, a year later, sometimes next week, but he says, man, same issue. We're having the same problem again. And that can happen a lot when we've reached the understanding part, but we haven't reached kind of the wisdom, the long-term trend. Bobby talked a lot about culture of quality, and that's where we get into this last piece is wisdom. So what does that look like in the real world? So we'll go through kind of a little bit of an exercise in how this DIKUW way of understanding data actually affects your department. So the first piece of that is the observation. So you may have a technician who's working on assembling a tray. They check it for cleanliness. Workstation's got blood on it. It's got mucus, bile, whatever. We all know what comes out of sections. So that's all over their workstations. And they say to you, this happens all the time. This happens every time I'm in assembly. I have a soiled lumen, a dirty section. It's coming through decontam. Well, that's an observation. So we'll kind of go back to middle school science fairs. That's your observation. Now you form a question. You can also form a hypothesis, but you're forming a question. How many dirty sections are we observing in clean assembly? One of the values of data is that it takes the subjectivity out of it. You get into a space where you're talking in real objective values. This is helpful for both a staff standpoint as well as dealing with the OR, because you don't want to hear, this happens all the time. My trays are always late. And we had we were very lucky our department was overseen by a general surgeon who was very involved in leadership. And so, and it was usually ortho, but an ortho doc would come to him and say, I never get my trays on time. He'd go back to them and say, never. You never get your well, you had 18 cases this week and you had one late delivery. Okay, so that's maybe a different question. So now that we have our question, now we're going to start to collect information. That's the I. So if we go through, let's say we go through 10 days of data and 15 to 20 dirty sections are observed in a week. Okay, now we have information. We need to put it in context, and that's getting to a pattern. So when we timestamp those, the majority of those may be occurring in the first 2 hours of second shift. This is also where it helps on the human end. The tendency for us is to say the error occurred on second shift. This must be a second shift problem. I worked all 3 shifts and night shift, and so I've heard it all across all shifts work hard. But the tendency in SPD is to attribute the error to the shift that observed it, and that's an awful practice. So then what you say is the majority of these dirty sections are coming in the first 2 hours of the shift. And then as a leader or as a technician, you can say, okay, why is that happening? Well, what's happening the last 2 hours of the shift? What's happening, or the first 2 hours of second shift indicates that the last hour of first shift, people were rushing. They were saying, I don't have time to soap, brush, flush this. I'm backed up. They just dropped off a ton of trays. I'm going to get them in the washer and get home. I'm tired. Well, what's the downstream effect of that? Now 2 hours into second shift, we've got dirty section, dirty section, dirty section. From an infection prevention standpoint, it's a nightmare because now you have patients who may be ill with whoever knows what. Now you've got environment of care concerns. Now you've got staff safety concerns. They may have been exposed to something. You're not really wearing the PPE in a clean assembly area that's going to be sufficient to protect you from whatever's in that suction. So we get a whole host of issues. So next we evaluate the process. We know when it's happening. We know what's happening. We put some definitions down. So now we're going to evaluate the process. A breakdown in process is going to come from 3 sources. I know, it's only 3. Pretty easy. The first is education. The next is equipment. The third is ethic. So education, that's going to apply to your training. It's going to apply to your precepting. It's going to apply to your standard work instructions for your department, your policies. Those are all resources for education. If there's a breakdown in one of those, it's going to manifest when you get to this process understanding piece. How many times have we seen, I was trained that way. Bob, that's how you showed me leak test scopes. Or they told me I didn't have to do that. So education breakdown. Then we can have an equipment breakdown. One of our process improvement projects was around the brushes and the lumen size. And so we go back there and we had a lot of ENT kits that are used a 3 French lumen, so pretty short or pretty small, narrow lumen. Well, we go back there and we ask the technician, where do you keep the brushes for your 3 French suctions? Oh, all of a sudden we're looking everywhere. We're looking under floor mats and in the bathroom and down in lab, and no, just kidding. But there was no brush sufficient for a 3 French suction in decontam. So that's an equipment failure. And unless you're physically going to the space and taking your data and then bringing it into the space, you're not going to know which kind of failure you have. The last type of failure we have is an ethic failure. That's the third E. So an ethic failure can manifest in 2 ways, and sometimes both. It can be a work ethic, or it can be a moral ethic. Now, work ethic, sterile processing, it's some of the hardest working people out there in healthcare. No other department is on their feet. No other department is lifting 25-pound trays for 8 hours at a time. It is hard work. However, there still may be some lazy apples. That's just the way it is. So if you have somebody that they're never brushing, never flushing before they send something through the washer, it may just be laziness. If you've done the education, you've done the equipment, then we have a work ethic issue. And it's okay to say that. We can't cover bad practices because we want to think that everybody does a phenomenal job. It's okay to say, hey, this person may need some retooling. So the next is you can have a moral ethic issue. The reality of the work that we do is that patients are always on the other end of it. So we had in my department what we called the Porter principle. And my son, his name is Porter. And because we worked at a children's hospital, it was very easy to connect those things. But we would talk about with new hires and staff meetings, we would say, your work has to be sufficient that if it's my son coming in, if it's your daughter, your niece, your nephew, your grandbaby, that your work is good enough for them. It has to be good enough for your loved one. And that's where the moral ethic comes in. I've seen some of the types of infections, some of the SSIs that come from improper practice, and it's always tough to narrow down, does that come from SPD or not? But when you see people who have no reason to be sick, they came in for a procedure, and then 2 weeks later they have a fever, infection, they're septic. We really have to connect the quality work that we do to that patient. So those are the 3 E's: education, equipment. Last is the principles. So we've done this data collection project, we've gotten improvements, and now what do we do with it? If you do all of this work and you don't change a policy, you don't change a practice, you don't change your training plan, what was it all for? You know, it's important that in order to build lasting change, we follow this DIKUW model clear to the end. So, all right. So how do we make all of this data useful? There is a process improvement methodology that we've all heard of, or if you haven't heard of it, it's called Lean. And it comes in part from this guy here. His name is Kiichiro Toyota. And his dad built and ran a loom factory in Japan in the mid to late 1800s. And then Kiichiro here encouraged his family to take what they were doing with looms and parlay that into the automotive industry. And eventually they started building motors and then automobiles, and it turned into the Toyota car company that we're familiar with today. So one of the reasons that their methodology became so popular was because they took a very systematic and practiced approach to improving outcomes. And one of those was with a method called the 5 S's. And those stand for sort, straighten, shine, standardize, and sustain. We're accustomed to thinking of these things in a physical space, but this also applies to the data we collect in sterile processing. We heard in earlier sessions about the just huge amount of data that we have access to in SPD, and we want to make that as useful and efficient as we can in order to drive outcome. So in order to do that, we apply this lean principle, and we'll go into detail on this. One of the reasons that lean as a concept came out of Toyota, it wasn't because they were a multi-billion-dollar company that said, let's figure out the best way to do this. It wasn't top down. What this was a new company being created and formed out of very scarce resources. So, and people throw around lean all the time, you know, they'll say, oh, we did a lean improvement. Say, okay, what does that really mean? It's kind of a buzzword, but it's good for us as SPD technicians to understand what it means. Because it's taken hold in SPD for a really good reason. And that's because when Kiichiro and his family were going into this new venture, they had razor thin margins. So they had low inventory of extra supplies because that's all they could afford. And they had to use those efficiently in order to not lose money and be able to drive the venture forward. In sterile processing, our margins are razor thin. When you think about what sterility of 10 to the negative 6 means, it's a 6 log reduction. So 1 in a million that something went wrong and that a pathogen survived. That's a razor thin margin. So lean has had a lot of impact in SPD because they have mirroring prerogatives and a very similar margin of error. So we're going to go into these and how they apply to your data. So first is sort. That's the first S. And the question we need to ask ourselves is the data we are collecting useful, and is it necessary? We all get tons of automatic reports. They come from your tracking system. They come from your safety reporting system. Every morning my inbox would be full of tons of just automatic reports. And you have to ask yourself, are these useful and are they necessary? Lean means, in one sense, slimming down the amount of information you're getting into what's useful. So indications that your data is not lean is that you're receiving non-actionable reports and your data is not connected to a KPI or a key performance indicator. Key performance indicator is another term that can be kind of a buzzword. So what does that really mean? A key performance indicator is not, we want to help patients be safe. Okay, that's a good goal, that's a good vision, but it's not a KPI. A KPI would be, we want to reduce the amount of wet trays by 30%, or we want to reduce the number of dirty lumens coming to the clean side to 0. Those are key performance indicators. It's something that you know where the floor is, you know where the ceiling is, and you know where you stand. So if you are receiving a report that's not connected to a KPI, one of the ways that you can reduce the amount of information that you're getting that may be not useful is to do what's called the red sticker process. So if we're doing this lean project, this 5S project in a physical space, let's say our decontam, what we're going to do is take a roll of red stickers or red dots, whatever you want to use, and we're going to put a red sticker on every item in that decontam space. When you use the item, you take the sticker off. So you're saying, obviously you're going to use that. I hope you're using that. You're going to take the sticker off. You have a chair sitting in your department that you put back there because the one traveler had bad knees and couldn't stand in decontam, and maybe you don't need 4 chairs back, whatever it is. You can put a sticker on it. If you don't use it, take it off. I've been in departments before where like there's 5 lockers for the same guy, and that's not very lean. That's wasteful. You'll see some people kind of collect stuff like that. So the red sticker process is helpful because after the point that you reach, maybe a month, you look at everything that still has a red sticker on it and you say, were we still able to do our work without touching anything that had a red sticker still on it? And the answer will be no, which means you can now free up space, you can free up resources by removing anything that doesn't have a red sticker on it. Okay. So you can also do this with your automatic reports in your inboxes. You may have set up a automatic report for a technician that was struggling, or maybe they were in their first 90 days and you were really watching closely their productivity. And now it's been 6 months and you're still receiving that report. So in the picture here, you can see all these automatic reports. These come from a safety reporting system. And then you can see in the bottom, I've taken and just flagged through the inbox. What's important? What do I need to use today? So then if I use it, I unflag it and I use the report. I'm sending it off, I'm rounding on something. If a month goes by or a week goes by, I can now look at all those flagged emails that I never unflagged and say, I really don't need any of these. These are 45 automatic reports that I'm not doing anything with. I can disconnect those from the automatic reporting. You can always build them back in if you need to, but it's going to cut down on the amount of useless information you're getting and also focus your attention more. Okay. Now, then we get into straightening. So once things are sorted and you have all of your excess items out of your space, now we're going to straighten what's in there. That means things are in the right spot and that you're having a dedicated purpose for each of those. One of the questions we need to ask ourselves with data, and it comes to straightening it out, is the time you are dedicated to collecting the data worth the solution you hope to arrive at? And that's just a long way of saying, is it worth it? Is if you spend 12 hours, let's say, building a report, collecting data to come up with a solution, but the solution only costs $5 to solve, was it worth it to spend your time making that data, collecting it, and building it into something that you then present? Sometimes it will be, sometimes it won't be. But time is our most limited constraint. One kind of way to, or an exercise to think about this is about 2 years ago, my wife and I decided we're not going to fly anywhere that's closer than 8 hours away. And why is that? Well, because you drive to the airport, it's an hour. Like I said, we've got a son, so it's McDonald's and potty breaks that take forever, and that just adds to the time. Check-in and security is an hour. Flight time is 2 hours. You get a layover, then you get there, baggage, rental car. So now we've built in 8 hours worth of our time, and maybe we've just broken even to flying there. So you have to make a couple considerations. One, clearly define what you're hoping to accomplish. If you're doing a cost analysis of replacing this type of instruments, one that we'd commonly see was instruments with delicate TC inserts, especially like an Adson forceps. We were sending them out for repairs so frequently that it became more cost effective to just purchase new ones based on a routine kind of framework. That worked for us, but it didn't take us a lot of man hours or thought to get there. We collected some data, we did a cost analysis, and then we presented it to the folks in charge of that decision. It wasn't something where we said for 6 months, we're going to see how many TC force Adsons, delicate Adsons we're sending out. Then we're going to talk about it at a capital meeting. Then we're going to do all this. This is where we get into the weeds of our data and we lose its effectiveness. Remember, we're hoping to arrive at the terminal point of that data. So clearly define what you're hoping to arrive at, evaluate the constraints, and then consider the bandwidth. Bandwidth is an important concept in SPD because you're not going to have time to do everything. You're going to need to pick and choose. You're going to need to allocate your resources and your time to what's going to drive effective practice for the patient. If you're a new supervisor, a new manager, a new technician, and you're just learning your job, really pause and evaluate whether embarking on a data collection and execution project is right at that particular time. All right. The next S, the third S, is called shine. And this is where we make our data pretty. We make it look good. So I saw this meme, and I had to laugh up here in the right-hand corner. And these are two men. They're both wearing, I don't know, he may be 16 or something. But these are two guys. They're both wearing suits. They're both wearing sunglasses. One here looks like he has a career. The other one looks like he has a court date. So that made me laugh because presentation matters. When it comes to data, it has to be or should be visually appealing. It has to be absorbable, and it has to be in line with what the person viewing the data thinks is important. So one way to accomplish this, and one way we can kind of see the contrast in this in data, is this graph here. So this is a really chaotic graph. I'm sure a lot of work went into it. Does it tell you anything? No. Just a lot of plot points, a lot of information, and nothing that drives a conclusion. Now remember, when you're taking your data and you're packaging it and you're shining it up and making it ready to present, you're going to want to use appropriate labels that mean something to the end user. So one way we can do this is if we look at average tray count at 7 a.m. as a function of staffing. Do you know what I'm talking about? Yeah, it says it right there in the table. And from this graph, it's a simple graph, and what somebody should be able to see is when staff goes up, Trait count at 7 goes down. And now we have that relation. The people who oversee SPD at a high level, your VPs, your C-suite, they may not know the nuance. And it may not be their chief priority, unfortunately, to learn the nuance. They're not going to care that here in June, Becky was on maternity leave and she's the person that does ortho, and that's why we had more trays. They may not care that in September you had a great new hire who, went back to college or whatever. And that's why, so that nuance is not going to come through in those meetings. What you need to say is very clearly defined. I need more staff, and you should care about this because when staff goes up, trait count goes down. Simple as that. Another way to kind of shine up your data or make it into a digestible format is through an SBAR. And it's a reporting tool that comes from the U.S. Navy, and that's situation, background, assessment, and recommendation. It's a great format, especially for communicating with executive leadership, the C-suite, and people that may just want the information, not the time. So we're going to go through a little bit of what an SBAR could look like. There's not too many rules with an SBAR. It's a pretty flexible format. But one important thing is it all should fit on one piece of paper. I can tell you from experience that it's hard enough to get executive leadership to read any emails, even when it's pretty important. They're not going to read a 5-page report on your process improvement project. There may be a time and a place where they do, but if you're giving concise, accurate information in a 1-page format, and they're used to seeing it in that practice, then they're saying they're giving me solutions, they're doing it quickly and effectively. It's driving change. So, an SBAR. So, situation, concise statement of the current problem. Background, relevant factors that preceded the situation. There's a general large turnover in healthcare, especially above a certain level. Sterile processing directors, maybe a 2 to 3 year average time in that role. Anybody above them, it's about the same, 2 to 3 years in an executive leadership role. Now that's in part because they move to different roles or maybe they move to a different facility. But the chance of somebody being in your C-suite that says, I've been here for 20 years. I know when this happened last time. I'm fully aware of the situation. It's not always going to happen. So you give them some background. You give them an assessment, which is going to be a summary of the data. And then you give them recommendation, which is going to be a concise course of action that's packaged in kind of a shiny way. So this is a situation that came up in one of our facilities. And the situation, red biohazard bins not available in dental clinic soiled rooms. That was the problem statement. We gave some background. In February, they increased their volume and extended their operating hours. So this is the point where if we go back to that DIKUW model, we have our observation, there's no red bins. They may not have stated it that clearly or that kindly when they called you about it at 4 o'clock in the morning, but that's how it's stated. So now we're going to collect some data. And data collection, we have this kind of framework or assumption in our mind that data collection involves a 9-foot-long spreadsheet with statistics and outcomes and formulas in Excel that make us kind of, queasy. That's not what data collection has to be. In the field of epidemiology, you are dealing with just huge amounts of raw data. And the goal for the epidemiologist is to take 20,000 vital statistics, infection reports, public health information, hospital data, and bring it down into one concrete recommendation. Solution will be generous. It's public health. But recommendation is kind of what we go by. So you may have all of this reporting data, soil samples, water samples of, especially in the summer, different types of pathogens in swimming water. And then you're taking all these, you're consolidating them until you say, 2 Mile Creek, you shouldn't swim there this summer. It's too many, too much of an emerging pathogen, too much Giardia. We're making our recommendation. So you're doing the same thing in SPD, but you don't have to pull a mountain full of data. What we made is a very simple tracker. It looked like this: date, time, number of bins delivered for SPD tech. For clinic staff, is red bin available, yes or no, and what time? So what time are you putting in your information? What time is the SPD tech putting in your information? Time stamping your data is one of the most effective ways to make it happen. So if your data says at some point in time we observed this, it's not helpful. Date and time. So we did this for about 2 weeks, and what we found was that after 3 or 4 o'clock, well, there's no red bins, and that's because they've extended their clinic hours. Second shift is too understaffed to deliver more bins. And so what we're going to do is make a recommendation. Due to staffing constraints in SPD during second shift and limited space in dental clinic, SPD will place additional bins in a tower storage area for dental staff to retrieve as needed. So in one sentence, you would put your data here in the assessment, but in your recommendation, you've told them what a solution would be, told them what you're willing to do, what you can't do, which is have second shift deliver a whole fresh set of bins, and then you're telling them why. Now, somebody's going to make the decision who brings more red bins, whether it's SPD or the dental clinic. You want to be able to show them the data and for it to be pretty clear that you've done your legwork, you know what's going on, and that you're coming to them with a very concrete solution. If you have had experience using SBARs, they can be a really valuable tool for purchasing equipment, capital requests, or process improvement. All right, so the next S is standardize. And if we were doing this 5S in a physical space, you want to make sure that all of your workstations look the same, that they are stocked with the same supplies. Now with data, you want to make sure that you're collecting in the same way, because you're not going to be there to collect data around the clock. And even your tracking systems, we talked about in earlier sessions, some of the limitations of tracking systems. So it's a good tool, but you're going to need a way to standardize the collection process. One of the ways that this happens is through a data collection map. And it's essentially a short standard work instruction for why you're collecting data, what you're going to do with it, how it should be tracked, and where it's coming from. So first element, a problem statement that outlines the purposes of the data. This goes back to your straighten step. Is the outcome you're hoping to arrive at worth what you're wanting to do? This is going to clear that up. Next is a divine source of the data. So going back to public health, are we pulling records from clinics? Are we pulling records from hospitals? Are we pulling them from self-reporting, screening calls? You have to use the same source of data every time. One example of this is if you're trying to see how long it takes for a tray to get from in the sterilizer up to the OR, you can use your tracking system for part of that, which is fine. You're going to know when the load went in. But if on the back end, you're relying on the circulator to say, what time did this tray get up here? You may have some shaky data. So the rules have to be really clearly defined. Just remember, like 50 minutes in OR time is like 5 seconds in SPD time. So you may have the OR call and they say, hey, I need this tray. 1 minute goes by, 2 minutes goes by, 3 minutes goes by. The tray gets up there. You may ask the circulator, how long did it take that? Oh, 20 minutes. I was waiting for half an hour. The doctor unscrubbed, went home, ate a sandwich, came back. The tray still wasn't up here. Okay. Well, that's just part of our reality in SPD. So data can really get you into that objective space where you're saying, no, I know that it took 7 minutes to get from when you made the call to the tray being up here. Last is instructions on how the data should be collected. Are you doing it with a time study? Are you doing a checkoff sheet? Are you doing a kind of handmade table like this? What's the instruction how it should be collected? Because you're going to want to be able to pass on something where your lead tech is tracking it the same way each time. And then the last thing is you want a secondary source to audit and validate your data. One story that comes up with data collection is back in the 1960s, Cold War era, they were very concerned about tracking nuclear warheads, as the risk of them was, okay, we don't want somebody getting the drop on any other country. So they built this huge radar system in Greenland. And when it went live, like a week after they started collecting data on it, had all these sensors, everything like that. Well, middle of the night, all the radar sensors start going off. Alarms basically look like a disaster. Full nuclear warheads, all fired. Well, if we were to only look at the data, if we were to only look at the monitors, the numbers coming in, would have looked pretty bad. Thankfully, some scientists stepped outside and saw that on the horizon was a full moon. And what these data sensors, state-of-the-art technology at the time, were picking up was on the horizon the full moon coming up. It wasn't nuclear warheads, it was just the moon. So you have to have a secondary source to audit and validate your data. If you're using tracking systems and it's telling you that your miner trays, the average time for assembly is 7 seconds, okay, that's because somebody's just assembling it and clicking through. So you need somebody to watch them and say, how long does it actually take? And then you reevaluate this map and make sure that your collection source is accurate. The last S is to sustain. And that's a question of how long we need to collect this data. One example of how you can write this into your map is we're going to see how often more than 20 vendor trays are dropped off at one time. We're going to check this every day for a month and then complete a root cause analysis based on our findings. So even before you start collecting the data, you know how long you're going to do it for, you know what the purpose of it is, and you know when the stopping point is. Going back to our first S, sorting, you may be collecting data that's tied to last year's KPIs, and you're now looking at something else. So you could have short-term data that you're collecting for rapid cycle improvements, short-term, like a root cause analysis, or volume throughputs. It doesn't take a year to figure out how long it takes to assemble a tray. Next, you may have medium-term, which is Joint Commission citation compliance. So if you have something where you need to show compliance for 4 months, you may need to show it for 30, inventory analysis, because there's going to be some ebb and flow. Collecting data on the 1 month that Dr. Wall is on sabbatical is not going to give you accurate data. You need to stretch that out. Same thing with productivity. If you collect a week's worth of productivity data, I can tell you that it may not be wrong, but it is incomplete. Like we talked about in the beginning, data needs context. You need context for productivity data. And then you may have some that are collected for over a year. That's maybe sterilization records, IUSS, or early BI release documentation, or equipment outage and repair reports. From an infection prevention standpoint, these are really crucial because we may have a situation where months after the surgery, we are trying to figure out, did the positive airflow in the OR go out that day? And we rely on people collecting and keeping accurate records. So know what your facility requires and then build your data collection map based on those short, medium, and long-term strategy or requirements. And a bonus S that I'll throw in here, this isn't part of the lean, but it is important, is to strategize. So is your data helping you get what you need in your department? If tomorrow you built an Amazon wish list of what you need in your department, what would that look like? You need education or somebody like Beyond Clean, I'll give a plug there, to come in and help you with training? Do you need equipment? Do you have new arthroscopic shavers that require a borescope? And it's not capital season, but we need this. Or do you need ethics? Do you need staff? Do you need employee appreciation funding? So what do you need? What's on your wish list? It's one of those 3 E's. And then you're going to speak to your C-suite, to your leaders. You're going to go up the chain of command and align your department initiative with organizational key performance indicators. So right now I work for a Bon Secours Mercy Health. It's a huge system. They're in Richmond and Toledo and all over the place. So there are ministry goals, and then there are market goals, and then there are facility goals. So if my ministry goal is to reduce the rate of SSIs, or surgical site infections, and my market or Cincinnati area goal is to reduce those in colon cases specifically, and then my facility goal is to do it with this particular surgeon or in this room, or so what I want to do as a sterile processing leader is I want to make sure that what I'm asking for helps support or falls in line with what the organizational KPIs are. So what that may look like is the market goal, the hospital goal is to reduce SSIs from ortho cases. Well, hey, I need a borescope, and my justification for getting this borescope is to reduce ortho SSIs. And now we have alignment. When you present that in an S-bar or a data summary, you're giving them very clear, concise, lean data that's going to allow them to say to their bosses, to their leaders, hey, you know what? Our SPD, they came up with a great way to help meet market KPIs. We got to buy them this borescope. And when things are looked at on that level, not only are you helping your department, your organization, but ultimately it makes the patient safer. The other type of strategy that you can have is to use this lean, mean data to create a network of impact. Like I said, SPD is the most effective arm of the infection prevention initiative. There are policies, there are best practices, there's technicians that learn and use their own time to make a difference. There's not many departments that you see that in. So when you do this work of collecting data, of making it useful, you now have a collaborative tool. If you need, let's say you need an RODI water system so that you can go from house steam to clean steam because your sterilizers are getting caked up and they've got particulate, they've got calcification in them. Well, you know who else uses RODI water? Facilities, dialysis, pharmacy. So you have already done the legwork. You know the value. Now you can go to other groups and say, hey, is this something you guys need too? Because 3 departments asking for a large enough RODI system is a lot better for a system or a facility than, hey, SPD, they're talking about what water they need. I don't really understand it. Something about Amy asked for something. But when you collaborate with other partners, it gets things done. If you are working to get improved training programs, you can partner with EVS, lab, scrub techs, the OR. If it's career growth, partner with the OR. And if you want to know process failures, how your work in sterile processing is impacting things on a patient level, talk to infection prevention. I'll put a little plug in there for IP. The important thing is that the process of learning and developing how to get this data, making it lean, making it useful, is going to be a tremendous resource as you make changes in sterile processing. So I want to thank everybody for attending this and participating in it. My name, again, is Garrett Hollembeak. feel free to reach out, email me, reach out to me on LinkedIn if you have questions. I'm always happy to put a bunch of data and we'll see what we can get out of it. But thank you very much for your time.
All right, Garrett, that was good. Thank you very much. Good way to wind out the day with a lot of talk about data. But I think we've covered a good broad base of it. You brought this up, and I guess it'd be the $1 million question, because I kind of go between this. Is it data or data?
I'm gonna have to look it up later.
Yeah, I mean, because it's funny. I say data, but then I also find myself saying data. You know, it depends on the context of how I'm talking through it, and I also see it more in terms of the part of the country where people are, where they've, you know. So I don't think there's a right or wrong answer, but thought I'd ask you.
Yeah.
So in terms of data, I know that the word, I think, could even be perceived as a 4-letter word, if you want to call it that, in the world of sterile processing and beyond. People think of data, people think of numbers, and it can be intimidating. So in terms of implementing a program, and this goes, I would say, parallel to what you're talking about on the lean side of things. If you're going into a department and they're looking to try to build some sort of reporting structure on the data side, how would you go about helping them implement some data reporting, say from the ground level? Say if they're looking to make the case at the C-suite for a new piece of equipment, or say their processes or their workflows are broken. How would you first identify the problem and then help them build that based on that? Or is there a structure on how to put together some data reporting? Do you have some insight on that?
Yeah, I think that's a great question, because depending on the type of thing you're trying to accomplish, you may not know, you may have a surface appreciation for what the issue is. But until you start collecting data, you then may go a level deeper and a level deeper into, this is the real root. If it's something like, let's say, delayed times to the OR, well, you may think that's just because somebody couldn't find a tray. Well, and then you collect data on time from call to delivery. And then you find that half the time when you try to deliver the tray, the OR is riding the elevator up and down to different floors, and phlebotomy's using that elevator, everybody's using the same elevator. And then you might find, hey, that's impacting our time. So you use one set of data to kind of point you in the right direction. Then you can specify it as part of that data collection map and say, okay, part 2, we're going to see how much time it takes for the elevator to get here. So it's a little bit of both. You use data to identify the problem, and then you use data to narrow down what your recommendation is going to be.
Right. Yeah, that's a great point, because I think there can be the way of thinking of, we need to solve this all in one data collection puzzle. And, you had the graphic there that is just, you look at it and you can't even present the case for, so I think if you simplify it in a way that you highlight it, make it, the less is more scenario. So show it here, the ground level, and then where are these cases being performed? What level, what part of the hospital are they? How long are they traveling? So I think that those are some great recommendations. In terms of the concise reporting, as we just kind of talked about, are there ways for departments to, to focus in? Because like we just said, you can get overly detailed and you can get in the weeds. Are there statistics or special or recommendations you would highlight for people to focus on keeping it concise, keeping it simple, keeping it understandable.
Yeah, I think that goes, and you're exactly right, because it's easy to get too many elements. And as a new manager, I was telling my boss, like, well, we can kill two birds. He said, well, you're not hunting birds. It's like, okay. So his approach was one bird, one stone. Keep it very simple. And one of the ways that you tie that is instead of tracking sterilization, quality, or you just take one. You say, how often are we not testing the sharpness of our scissors? You collect it in a short time frame. And then the other half of that is when you go to these reporting meetings, if you don't have a meeting charter or action items at the end of those, it's an opportunity. So if you have a monthly touch base with your OR, you need to have a stated purpose for that meeting. And then if one of the reasons you're meeting is we want to shorten turnover times, then when you collect your data, you're going to present that as I did A to help us better understand how to shorten, insert charter, how to understand shortening turnover times, and we need to do C. So that helps keep things really simple. It also helps keep the focus of those big meeting groups that we sometimes go into.
Right. Yeah. And the collaborative aspect that you highlighted, I think that really does help bring people together in terms of just showing how it affects each department. Yeah. One of the things too, you think about implementing these programs, you have tracking systems, you have spreadsheets, you have things that can help with these data practices and implementing these programs. But say, for example, a department doesn't have a guru, doesn't have a process. Who can they go to help them implement these programs? Like, who's the person that can? I mean, it probably wouldn't be an IT person because they don't understand the process flow. But is there, would it be a vendor? I mean, without calling out a specific vendor, do you have some recommendations on that?
So I would always start in-house. We were, again, lucky. We had some data analysis folks that were really good about building these and formatting them in a way that the C-suite was used to seeing them. If that's not a group that you can talk to, or if they just don't have the bandwidth to take on an SPD, I would say start with your quality department, your regulatory department, or your infection prevention group. Those three groups they're in data every day. They're talking to the right folks. They're already reporting that information out, and your solution may be the thing that they're looking for. So I'm always happy to hear about, hey, we did this and we need help getting it to the finish line, especially from IP, because you can really leverage their resources to get the outcome that you need.
Right. Well, that's great advice, and I think that like you said, there are departments that can help. Each department can help each other, and there is an end result, but sometimes, as we said, it's a collaborative effort. Yeah. Well, Garrett, I think we're at time. We're about ready to end the day. I do want to also highlight the fact that you, as all of our speakers, all of us are in this for one reason, and it's the patient. There's a patient on the end, and it's not just my dad, my mom, or my immediate family. It's all of our families. And so in terms of thinking about that, it is going to affect all of us at one point in time throughout our lifetime. That's just the nature of it. So there is a patient at the end of all of this, and we need to think in terms of the patient and how we really bring them on the other end as far as the successful outcome. So Garrett, thank you so much, man. It's great to have you on with us. You always do a great job. You do a great job for us in other regards, so really appreciate it.